I am with Capital Regional Medical Center, but I am an independent physician. You are looking at the end of those individuals. They're all going to be working for this guy soon, okay? So this comes out of the fact you want to know why you're seeing a nurse practitioner, not your physician. You want to know why you don't have enough services. Why aren't you seeing these people? Why aren't they coming to you? The answer comes out of the fact that there are fewer people going into medicine. The cost of medicine goes up. If the average cost for a medical student right now is about $300,000 a debt. Currently, what's been happening to us is insurance rates have been flat. Medicare has been paying us less. And so you get the extended providers, which cost less, to take that position, the role of the physicians you used to see. So you have to look at the business side of medicine. That's what I do. The current cost right now for the average cost for family practice is an overhead of 65%. 65% is what it costs for them to manage that clinic, because the insurance companies ask us to do more services that are unpaid. We have to do approvals for your medications. We have to do approvals for your procedures. All that has to be done with manwork. So that requires individuals to be hired to do that. But we're not paid anymore for that. Those are non-reimbursable services that are come to the burden of that office. Okay? And anybody in the healthcare industry will probably agree with that. So it costs more to go to medical school, and you're not getting paid more. So if you're a bright person, are you going to go into a business that has a negative cash flow? Are you going to go into that kind of world? Or are you going to work on something else, like maybe leave the little town of 900 where I came from on the Canadian border and come and work in the science industry where I can make more money, whether it's computers, some of the stuff you heard earlier today about telecommunications. Why shouldn't I go there? Why should I go into medicine? Okay.
If I asked the American Medical Association, should we double the number of slots in medical school, what would their answer be?
Well, there's a response by that. It's a very interesting response. I'm an allergist, immunologist. I'm a DO by training. I can't leave my family practice roots. I have lots of patients who see me for non-allergy immunology issues. Just the stuff I've dealt with already this morning had to do with thyroid issues and other things. But the response by the American Medical Association and the government is that we should make medical schools 3 years and fellowship or residencies 2 years. So what I do? What kind of education did I have? Well, I had 4 years of medical school, 3 years of residency, and another 3 years of fellowship to do what I do, to get certified in my area of expertise. It took that long and that much education. So their response is to have less education, less training, and that's going to make a better provider. Well, what their theory is that reduces the amount of time you're in medical school, reduces the amount of time you're in residency, and in theory, that's going to reduce the cost. But let me tell you, the medical school is just going to add that 30% back to the cost of going to medical school for 3 years. They're not going to lower the price because you cut off 1 year. I'm not quite sure where the brilliant people came up with that thought, but that is what is out there. And I've heard this at least 2 times in family practice meetings that I've gone to, where they've had their representatives from the national capital come and talk to them. So
I think the thing you have to understand about healthcare is healthcare is only a priority when you need it, quite honestly. And unfortunately, with broadband you use daily, with transportation you use daily, with healthcare it's used intermittently. And quite honestly, it's on average it's about 3 visits a year per user, and so it's become very complicated and it's very challenging. And as he said, administratively, I think the success of programs like federally qualified health centers, as well as hospitals and things, is because they can divert or spread those administrative costs out over multiple sites and multiple people. And so I think that's part of the challenge. The day of the independent provider is going away. It's not going to exist. And there's going to be a lot of other professions. I think dentistry will follow that within the next 20 years or so. And it's just going to become prohibitive. But unfortunately, especially in family practice, which is one of the lowest paid specialties in healthcare, but requires the most work in healthcare. And if you compound that by putting a rural general practitioner or family practitioner in a rural setting, there's no rest. I mean, quite honestly, the rural providers I've had the privilege to work with and things who've become engaged in their community and such, they don't go to the grocery store without seeing their patients. They don't go home at night without getting the routine call and things. So it creates a lot. There's a lot. It's just not administrative. There's a lot of demographics to it that we have to be conscious of.
I was asked to come in from Iowa. We were one of the states that did expand Medicaid. We were seeing thousands of patients a year coming into our practices, into our hospitals, and our docs were just not getting paid for that care. That was adding to the administrative overhead for them. So we wanted to find a way to move forward and expand Medicaid, recognizing that we are politically split in our legislature. So a traditional expansion like DC wanted to push upon us was not something that was palatable to a lot of folks in our state. What we did was a hybrid model similar to what Arkansas is currently doing. We split it at 100% of the federal poverty level. Below that, we did a variation of traditional Medicaid expansion. Above that, from 100 to 133, we used federal dollars channeled through the state to purchase private insurance for folks. Wasn't the most successful model, but it did drop our uninsured just in the first 6 months, $33 million in charity care in the state was eaten up by this. We got 150,000 more folks coming in that actually have coverage now, but still we struggle with these challenges as well that we know. In Iowa, we like to say that coverage doesn't equal access. Just because you have coverage under our Medicaid expansion doesn't mean that you're going to be able to get into Dr. Brooks.
Okay, Dr. Horner can't see those Medicaids in his office because he gets 16 cents on a dollar when I see them here. So I don't have Medicaid contracts here. I have one that I negotiate rates for that are about Medicare rates. So there's a difference in the population of healthcare and how it's distributed amongst the caregivers. So it's not just the fact that, the hospital, it's given a different rate if it has a FQHC. It's different if, and he's referring to the dentist relative to that, I believe, because dentists are part of that FQHC. So it's psych, dentistry, as well as general health care. So
explain your acronyms.
Well, that's a federally qualified health center. Okay. And one just moved in Audrain County. This is over there. And what happened to the rural health clinics is their statuses went from different levels to zero. So that affected, for example, the physician's ability to pay back through those federal health or federal rural health centers for their education. So now those doctors owe money because they failed their ability to pay back their education because their status changed. So there are lots of little strange, weird things that are happening. And people have to understand when your doctor disappears, that may have happened before because they had to relocate somewhere else to be able to pay back their education. So those are things that everybody needs to take a look at in their counties. When you come down to it, when you're looking at your healthcare in the counties, what's being provided, and how those providers are giving those services.
Primary resource initiative for the state of Missouri, PRIMO. Forgivable loan programs, that sort of thing. Haven't kept track to where we are within that. At one time, it was to be a line item budget, et cetera. And of course, that was state legislation situation. Bring us up to date with that, and that train your own, grow your own concept of bringing those individuals back to the rural communities.
With regards to PRIMO and what, commonly when we talk about PRIMO, while they have other components, I think the most important thing about PRIMO was the student loan repayment program, which allowed many providers to come back to rural underserved communities and they'd get part of their debt forgiven. It, like many things, has been subjected to budget cuts and such. In 2005, that program had $8 million towards it. This year, funding for that program was $2 million. So it's dropped dramatically. But what has kind of picked that up on the backside, and that was passed along with the Affordable Care Act, is that the National Health Service Corps repayment program has almost exploded, quite honestly, in size. And we're going to experience that for the next 2 years. And what that is that's through the federal government. If you If you go to a HIPSA in the state of Missouri, and I think there's, and please don't hold me to this, I think there's roughly 84 counties in the state of Missouri. Most of Missouri, quite honestly, is a HIPSA designated state. You do get your loans repaid back. And that can go out for as much as 5 years. It's $32,000 a year for 5 years. $7,000 of that, of course, is taxable that goes to the federal government to pay back. But it's one way that graduates out of medical school, also nurses and such, can come into the rural setting and get their loans, in fact, forgiven and taken care of.
So in Iowa, we've had similar loan repayment programs that were fully funded by the state. And over the years, they were an easy target. They got chipped away and chipped away and chipped away. And just in the last couple of years, because they were down to zero, we were getting no state funding, so those programs just went defunct. We worked with our family physicians on a joint loan repayment program where we committed that we will match every single dollar that the state puts forward. So because of that, now we've been able, and we've worked very closely with the Farm Bureau in Iowa and our large insurers. They obviously have a vested interest in getting those folks out into the rural communities. We've been successful in getting that back up to about a $2 million a year appropriation from the state, and then getting private folks to match those dollars and get them out into the rural communities. And just in the last year, because we've had such success with the physician level, we've been able to drop it down to the ARNPs and the PAs and some of those other mid-level folks as well to get that further expanded.
Again, working with the Ozarks Medical Center, they have a grant, I think it's $1.9 million that they acquired for telemedicine. One has to look at the telemedicine, how you can utilize that. Most of it is the codes are through CMS, which then gives us certain abilities to be able to work. Like, for example, as a specialist, if I am consulted by a rural health clinic, FQHC, a hospital, post the patient's been discharged, they're asking me, Dr. Horner, can you consult on this patient because they have an unusual rash? We can pick that. Or they may be allergic to medications. Can you help us assess that? I can get access, through that. What I have to have is a secure system. My cell phone has to be secure because I can actually use my cell phone. They can take pictures on the other side and send that information to me. The quality of the camera in the cell phone is better than some of the older technology that was used. And I can zoom it down. I can look at that lesion. I can help them address that. You currently are using that right now, and it's being done through a place that is probably about 10 miles from here. You call it JCCC. It is the prison system. They are using telecommunications to look at prisoners, and I actually was involved in some of that over there. And so I diagnosed patients that were in Kansas City, that were in Chillicothe, that were in other places. So whether you know it or not, the state is using telecommunications and telemedicine right now. It happens to be the prisoners who are getting the benefit because you don't want to transport prisoners to a public facility. It's very expensive. You have to have 3 or 4 guards, you add your overhead, but why can't we just communicate from one place to another? So it doesn't require that much. Yes, you need a high efficiency system to send that information, but you can actually, I can do it with a phone. So it really is, those are the kind of the minimum requirements necessary to set up a telemedicine-based clinic. I'm also interested in other benefits that should come to you. I've been working with some people about mobile infusion centers to be able to get chemotherapies and medication treatments closer to you. Why do the patients have to travel long distances to come to an academic center to receive their therapies? Why can't you just save some diesel or gas and do it locally? So there are lots of other opportunities out there. For example, I can do a cardiac echo on any one of you here and remotely with a device that's not much bigger than a little, CPAP. I also do sleep disorders. I do home studies on people that is done by satellite real-time transmission to Maryland where they're interpreted. You don't have to go into an institution. Now, this is not something so happy, I guess, to hear next door unless the institution is involved in it as well with the private sector and other cooperative groups.
At Jordan Valley, we're we're privileged. We have a very robust mobile program, which includes 2 dental trucks and 3 primary care trucks. Among other things, we service 21 school districts that are outside Springfield area. What we have found out in the dental trucks, they're utilized to a significant extent. Primary care trucks are not used to the degree we hope. And so what we're doing, and this is our first year, we in fact are putting telehealth equipment in the schools where we have serviced them previously with the trucks. And we're doing that in an experimentation model for the nurse to be able to, in fact, and I believe that we can get temperatures and blood pressures possibly and things of that nature. And quite honestly, they will be connected to our nurse practitioners or our physicians, and we'll be able to consult over the phone on telehealth and whether that child should be sent home, whether they should be referred up to another medical practice or something like that. I'll be honest with you, and I would. This is totally Brooks Miller's opinion after 31 years in healthcare, but I think that we will see in my lifetime that we will have touchless healthcare. I know there's experiments going on the northwest part of the state with the hospital, I believe, out of St. Joe, where we have patients that are staying at home and they are being monitored by the hospital. And these are all mechanisms to reduce the cost of healthcare delivery, the infrastructure that exists, and such like that. So I believe that we are just on the forefront of what telehealth is going to be in 5 to 10 years from now.
I would remind all of this is very expensive. And this is, if it's not paid for, it's not going to be done. The large systems in Iowa, we have 2 or 3 are predominant systems in the state, and they're able to offset the costs of acquiring these technologies and implementing this in their rural clinics. But our independent rural clinics, they just simply can't afford to do it because it's not paid for by insurers. We just this year were successful in getting Medicaid to agree to start paying for telemedicine services. So that's something that I would encourage the policymakers in the room to look at how your Medicaid program is addressing reimbursement for telehealth services. I would say get your local folks interested in medicine and interested in healthcare. If they are from a rural community, they're more likely to want to go back to a rural community to care for folks. Trying to get someone from India or from New York or from a large urban center to want to go to rural America is a lot more difficult than somebody that just grew up down the road.